So I'll be talking of some of these interesting cases that we overlook in our clinics. This was a 50-year-old female presented with pain, redness, watering. Apparently was all right a month back, accidentally put some Ayurvedic balm in her eye and was getting treated as a bacterial ulcer with a lot of drops with no relief. And this is how she presented with an epithelial defect and thinning and vascularization. What are we dealing with? If we look at the fellow eye, all our attention actually went into this eye with the history of something falling into the eye. If you look at the fellow eye, it was stained with SPKs, and probing a little deeper, she had multiple joint pains, morning stiffness, and typical history of rheumatoid arthritis, and she was not on any treatment for the same. Further investigations proved her to be suffering from rheumatoid arthritis, subsequently underwent tissue adhesive. And a similar case, this was another patient who presented to us post-cataract surgery 20 days prior with an epithelial defect and clean base, complaining of pain, redness, irritation after cataract surgery. What's the fellow eye status? It was an empty socket. What had happened in this eye? Had a cataract surgery 6 months back, again had keratitis and was eventually eviscerated. The patient was on a cocktail of antimicrobials, and on further in history, we found that patient again had joint pains, small joints, dry mouth for a few years. And this was again a patient of rheumatoid arthritis who had been left untreated, and the surgical trauma led to the sterile corneal melt. Subsequently, with DMARDs, the patient recovered and finally had a 636 vision. This is another patient presented with a history of female 55-year-old with pain, watering for 1 month of 1 month duration, had epithelial defects, scleritis, and this infiltration in the periphery. Case of PUK, on investigations, the C anchor was raised, and that was an indication for this disease to be associated with Wegener's granulomatosis. Further investigation also found that she had upper respiratory tract issues, and the patient was put on immunosuppressions. And finally, the patient healed with thinning and scarring, eventually underwent a phacoemulsification after several weeks after the patient was stabilized. However, the disease did get reactivated after surgery. So a lot of these patients do require systemic evaluation. And as ophthalmologists, we have to remember that the disease is not just in the eye, and we have to look further. And we need to look at their systemic conditions, get their blood investigations, and the answer may lie in systemic problems. This was a 52-year-old gentleman who complained of persistent redness, discomfort, watering after a cataract surgery. As you can see, the patient had meibomian gland disease. And on our Indian skin, sometimes it's not very easy to discern, but basically this patient was suffering from rosacea for several years. On this Wegener, much easier to tell, and complained of multiple chalazions appearing at different times in his life. And on the Caucasian skin, of course, it's much easier to tell, and he is still having rosacea. I think in India, a lot of it remains misdiagnosed. The new association of rosacea is with Demodex, and here's a series of interesting patients we have. This was a young patient, had 618 vision and 15-year-old in 2011. In the left eye, 6/9, florid vascularization, recurrent inflammation, like marginal keratitis. various diagnoses, various treatments he had received, and it was worsening. The patient was even put on immunosuppressants, needed Boston scleral lenses for his vision. And it continued to progress. And of course, the patient was frustrated and depressed. And also the doctor treating doctor, myself, extremely distressed as the condition. Till we learned what it was. It was basically, we pulled out a few lashes and we see this mite under the microscope. And since then, we've been diagnosing several patients with demodex. And it's quite common to see. Most of these patients, a lot of them are young, with good hygiene. And we've variously been treating them as PUK, Tyrians, even acanthamoeba keratitis, and we found a lot of them were actually demodex. And demodex mite can easily be seen by plucking the eyelashes and then seeing under the light microscope. And you see this creepy mite moving around. It's treated with tea tree oil and ivermectin. Yes, the same ivermectin being used for COVID. And this is a condition I think we today need to keep in mind. And we have this paper in IGO recently on our case series. This patient complaining of photophobia and a lot of SPKs. And you realize that this is essential blepharospasm. I think my video is not working. And essential blepharospasm could be the cause or the effect. Another young patient who had a history of alcoholism, drug abuse, having ulcers in the mouth and stomach, and presented with this epithelial defect, very dry looking conjunctiva. I'll just finish. And further investigation, we found ultimately needed a keratoplasty. Didn't know what we were dealing with till we got a physician opinion. And this was actually a case of malabsorption and vitamin A deficiency. So as we've been discussing, dry eye is a multifactorial disease, and one has to look at systemic issues as well. And a lot of these diseases can be confused, and we need to keep an open mind to find the diagnosis. Thank you so much.